I am just thrilled to be able to be with you guys today and to be talking about child neurology. I, like you already can see on the slides and I've heard from Genevieve, I am a child neurologist and really just very excited to be sharing this exciting field with you guys. I didn't know about it in medical school when I started. I knew I wanted to be a neurologist. I was one of those, but I didn't know I wanted to do child neurology because I didn't even know it existed. And so just really excited to have this opportunity to share the kind of breadth of the field with all of you guys. And I'm happy to be a resource for you as we dive in. So hopefully you can all see my slides. I will have the slides up through the first part of the meeting, and then I'll stop sharing the screen and then you guys could turn on your videos later if you wanted to, and we can have some more of a discussion. But I'll probably save a lot of the chat questions for the second half, and we'll just kind of dive in. So the first image that you see there is actually my daughter Felicity, and I made that special shirt for her. It says "My toes go up," a little neurology joke there. For those of you who know that a Babinski sign in neurology is something that we test on all of our patients. And sometimes people are surprised to know that upgoing toes are normal in infancy. And so a little neurology joke for myself mostly and my family. But all of my kids have these little shirts that I made for them when they were little. So here we go. So just to give an overview, I'm going to talk a little bit about my journey to child neurology and then give an overview of the field itself. And then we'll pause for Q&A for the last. So I throw in this quote for those who've seen The Mandalorian, just because I think neurologists in general are a pretty nerdy group, but we do have some cultural relevance. And I think this quote came to mind when I was putting together the slide, because I think some of these chat sessions or subspecialty discussions are supposed to show you like the way to get to the one path. And really there are so many ways to get to the future that you might envision for yourself. And so I put it up here kind of in jest to say that this is one way of doing it. It's not the way, and there are many ways, but I'm going to try to outline probably maybe a common path to get there. So a little bit of my background. I grew up in Colorado. These are pictures of all my kids. You'll see them interspersed throughout the presentation, but it was pretty typical growing up, but I started to be really interested in kind of the intersection of health and behavior from growing up in Colorado. Colorado's a really active state, and people make choices, you know, depending on what they're exposed to. And so I think as I was exposed to what people's normal patterns were and just kind of normal behavior, and then thinking about what was the biological basis or physiological basis for people's decisions and their patterns, noticing that the way people behave in Colorado is not necessarily always the way that they behave in other places in the country. And so really got started thinking about why that might be, and through high school and other kind of exposures to biology and what makes people do the things that they do, some basic psychology things too, that got me really interested in the brain. So after growing up in Colorado, I went out to the Northwest to Puget Sound and studied psychology. Did do all the pre-med stuff too, and a little bit of French along the way. Did the whole study abroad thing, and just kind of was exploring more about that underpinning of why people do what they do. And kind of thought about medicine because I was doing all the pre-med stuff, but wasn't for sure that I was going to go there. So decided after college to take a few years and kind of explore what medicine might be like. I tell people kind of, again, joking a little bit, that I tried to talk myself out of medicine for a while because I just knew that it would be a hard road. It's a long road. I was right about that. But so I did a bit of, I was a research assistant at OHSU for a while. My first experience having a pager, which was super exciting at the time. Didn't quite realize what having a pager meant in terms of being available outside of work hours, but it was just super exciting to me to feel like I was part of something and contributing and, you know, important enough to be on call for things. So that was a really just fun time. Also got a lot of kind of real life experience about what neurology looks like, and I did specifically stroke research at that time. So what clinical trials look like, what does it mean to work with patients in a clinical setting, but also for the sake of research and what's all involved there. Did some volunteering and also just got to find my passions as a young adult. So that was great. And then from there, I went to Minnesota for medical school. Again, like I said at the very beginning, thought I wanted to be a neurologist from the get-go, which I know is not always the case, but just with that background experience and having seen neurologists in real life, I kind of knew the dynamic nature of the field and knew I would be a neurologist, and really thought that the only way to do that was to be an adult neurologist. And so when I did my pediatrics rotation in my MS3 year, kind of was disappointed because I thought to myself, you know, I really like pediatrics. It's so fun. These people feel like a good fit for me. But too bad, because I'm going to be a neurologist and I know that that's what I want to do. So then someone said to me, did you know that there is child neurology? And I honestly had no idea that that even existed. I knew that there were other pediatric subspecialties in other parts of medicine, but I didn't know that neurology was one of those. And so once I figured that out, I had to do a little bit of reckoning and reconciling within myself about, you know, this thing that I thought I was going to be all along. But in looking closely at both fields, a lot of it for me came back to the psychology piece of it, knowing how much psychology had played an important role in why I got interested in neurology in the first place. It ended up that I felt that child neurology was a place where I could impact the psychology of the person affected by neurologic disease to a greater extent. Let me speak a little bit more about that. So I saw in adult neurology very commonly that when someone would get a neurologic disease, whether it was have a stroke or be diagnosed with MS or seizures or other things like that, that there would often be this kind of sense of resentment and that they would feel for quite a while, maybe for the rest of their life, that, you know, their prior self as compared to their new self was quite different, and that there would be a really hard kind of process to integrate those two things. But in child neurology, certainly that can be the case, but very often you have the opportunity to help a child, a young person, kind of form an idea of themselves that is whole, that integrates their neurologic disease into who they are, and for them to emerge as a whole person psychologically into adulthood. And that was really, really appealing to me, just as a foundational difference about the two fields. I'll speak a lot more about what I love about child neurology, but that was one of the big reasons when I was in med school that I decided to pursue child neurology. I also had a baby myself in medical school, and I think maybe you can see my cursor there, but this little puffball down in the bottom is in the front carrier in medical school in Minnesota. As you all know, it gets quite chilly, and this was one of our first excursions with our infant in the front pack, all bundled up to go to an ice bar. So that also just was, you know, part of my narrative in terms of how I wanted to balance my life and my work and all of those things. And so I just point it out as an important part of my trajectory as I was becoming a child neurologist. I talked a little bit about this just in terms of my personal decisions. I knew neurology from the beginning because of that dynamic nature of it that I talked about. But I also, to me, neurology is just so profound. I think a lot of people frame that as kind of mysterious or exciting or enigmatic, but to me it's this sense of a deep sense of meaning about your nervous system controlling who you are and being the seat of, you know, your abilities and your relationships and all of those different aspects of it. So I really have loved that sense of the neurology work since from the beginning. Again, it is very dynamic. There's so many discoveries happening. It's also very methodical, and you have a system to come back to, and that was always really reassuring for me as well. The child neurology piece, I just have fun. I think I think that you know, neurologists in general have fun, but child neurologists do a bit more play, perhaps. And I mentioned the psychological piece, and then people always will tell you, I think if you ask the most adult neurologists or child neurologists about one of the big things that they thought about in the comparison is feet. You know, that people who've done their neurology exam training have learned that you always have to examine the feet. And feet can be really stinky and smelly in old people. They can be in adolescents too, you get a lot of that. But in little kids, they're just so cute. And so nice feet is also a part of the rationale for some people. So after medical school, I matched at the University of Colorado. The child neurology training is generally a 5-year program. It's people call a 5-year combined program a categorical program, which just means that your general pediatrics training and your neurology training are linked together at the same institution generally. You can match for a pediatric spot separate from the child neurology spot, and that's how it used to be most commonly. And that would be an advanced spot in child neurology instead of a categorical spot, but most commonly now they're linked together for all of those 5 years, which is how I did it. So again, years 1 and 2 are in general pediatrics. Some institutions do a dedicated adult year, which is what my institution did. So for my entire PGY3 year, I was an adult neurology resident with their PGY2s, because in adult neurology, you do 1 year of internal medicine and then your 3 years of neurology. So it was the adult PGY2s and the child neurology PGY3s that did that year together at our institution. Some institutions, those months of adult neurology are interspersed throughout those 3 years of neurology training, and there's pros and cons to both. So that would be a question if you're looking into programs as to how they handle it. And then for me, the years 4 and 5 were dedicated to child neurology. And then following that, I did a fellowship in palliative care, which I can talk about later, but it's kind of beside the point for this specific lecture. I had 2 more babies during the course of that time. So I had another one during PGY2 and then another one during between 4 and 5, essentially. So I have 3 kids, and happy to talk about how that integrates with my life as well in medicine. So now, where am I? I am attending, and I made it all the way. So nice round 10 years of medical training, which went by fast and slow, depending on the time point. But I do work a full FTE. Right now, I am mostly outpatient. I do some inpatient, which is actually on the palliative care side. It's not on the neurology side, but it would be fairly common for people to do a certain amount of inpatient child neurology work as well. My split is actually 50-50, so half as a general pediatric neurologist and half as a pediatric palliative care doctor. And that my goal within that is to build pediatric neuropalliative care, which basically just means helping children and their families who are affected by neurological disease or serious illness have as much quality of life for as long as possible in the course of their serious illness. Right now, my setup is that I don't have any night call, which is really exciting. I do work about 2 to 4 weekends a year of pager coverage, but that was kind of a setup that I wanted, that I was looking for my attending job. And that's my profile there. If you look on the web, you'll be able to find that profile. So that's kind of my black and white setup right now. My family setup as an attending is just as full and fun as it has been all along. I think as an attending, I get a little bit more freedom to create my own vision. You know, when you're trying to get through training, you have a lot of boxes to check off that are other people's boxes for you, and those boxes continue to exist when you're an attending, but you get a little bit more freedom to also say what fits for you and what kind of thing you're trying to build or facilitate through your work. And so I do find that I have a little bit more freedom to figure out my boundaries and my balance of work and play, and that just comes down the road. But it's been there all along too, and it's important to continue to hone that, your boundaries and your ability to play even during medical training, and I'll talk a little bit more about that. So now we'll talk about the child neurology piece of things. Just as an overview, child neurology has really incredible breadth, and we'll talk about all the different types of child neurologists there are, I think, on the next slide. But there also is an incredible depth, and we're in high demand constantly. I'm always getting emails from recruiters about working in various parts of the country, really all over Alaska, Hawaii, any region that you want to. And there's a really great community. We're smaller than the adult neurology community, and so people really know each other and collaborate. And there's just potential for all sorts of basic science as well as clinical science opportunities, as well as, I think, evolving right now, which is something that I'm involved in, kind of like the social science aspect of it, supporting children and their families, and getting to really engage with kind of how things work from a societal level. Some of the health disparities work comes into. So we put these pictures kind of up there to demonstrate, that there's all sorts of work being done on genetics and gene therapy and basic science, bench work, whether it's cellular receptors in epilepsy or gene treatments for many of our diseases in child neurology, or characterizing neuroimaging, MRIs, all the different types of ways that we can investigate the brain now. It's all very exciting and it's all very relevant to the field of child neurology. So I tried to list here kind of a different view of how you could be a child neurologist. If any of you have tuned in to the other subspecialty discussions, you can take any of those subspecialty discussions pretty much and be that version in child neurology. So there's not just one way to be a child neurologist, and each of these individual areas that I've listed are coming into their own, often having fellowship opportunities, definitely research opportunities. I would say the epileptologists are probably the most common subspecialty within child neurology. That's kind of the most standard path if you're going to subspecialize further within child neurology. But all of those options there are people that I work with in Colorado, different kinds, different flavors of child neurologists just in the clinic. And then on the right side there, you can see that the hospitalists are coming into their own too. There are people who do neurocritical care fellowships and see children with brain injuries or are in the ICU with brain diseases. Even the same in the NICU, the neonatal ICU, that can be even further diversified from just the general pediatric ICU. Again, there's vascular and stroke neurology, which is a big section within the adult world that can be applied to the child world. There are people who do procedures, if that's something that you're interested in. They're not always hands-on procedures, but reading EEGs is a mainstay, and doing electromyography, doing those muscle tests and nerve tests. People read sleep studies. And then our LP, lumbar puncture knowledge and expertise, I think is kind of resurging a little bit because of all the opportunities for therapies that are being delivered intrathecally. And so certainly from a diagnostic standpoint, people sample cerebrospinal fluid frequently to try to work things up for patients, but we're also using it as a means to deliver therapies now, specifically gene therapies. And so I think there's a greater emphasis coming back around on neurologists having that skill set too. I mentioned a lot of roles for the physician scientists. I think I probably did that too little of service to list there, but those particular realms in genetics, looking at natural history studies about how neurologic diseases evolve on their own. And right now, a lot of them are kind of getting reclassified as far as what does this disease look like once a gene therapy is on board. So a lot of really exciting science happening, as well as the neuroimaging. There's a lot of molecular science happening too. So just kind of trying to give that broad overview for child neurology. I'm going to talk real quick about kind of some of the bread and butter things that we see in child neurology. I would say one of the most common complaints that come into the neurology office is someone having a spell of some sort. They've had these episodes. Oftentimes those episodes have brought them to the emergency room, or at the very least to the pediatrician. They usually have a video or two, sometimes on their phone, because they've been trying to show people and ask what the heck is going on. Sometimes they don't have a video, but it's sure helpful when they do. And so we talk a lot about what did the spell look like? Was it a spell that happened the same every single time that it happened? Or is it a spell that just happened once and not again? A lot of these things, as you can imagine, are really frightening to people, because what I mean by spells is something that alters the normal way that you function. So it can be really across the board. Maybe it was an episode where the speech was strange, or an episode where someone had drooping of their face, or an episode where maybe their whole body lost tone, they fell to the ground, or maybe their whole body stiffened. It can really be quite broad, and there have been spells that I couldn't even make up if I tried. People come up with all sorts of things, and we have to help decide, is it something related to a dysfunction of their nervous system? Those of you MS4s on the call, and maybe even some of the MS3s who've done their neurology rotations, probably could say that spells, when we're thinking about them, we try to put them into some buckets. And so one of them would be seizures. Is it related to abnormal electricity that's involuntary in the brain? Is it related to something like a stroke or like a cutoff of circulation somehow, or a bleed, some problem with the blood vessel that somehow shuts down an area of the brain or makes it function less well for a period of time? Or is it something like a migraine phenomenon that can also have really strange presentations depending on what area of the brain is affected? And kind of the opposite way from a seizure, where there's excited parts of the brain, excited cortex. We think about migraine as depressed cortex or cortical spreading depression. And so that can also take areas of the brain kind of offline for a period of time and present as kind of funny spells, even if it doesn't have pain accompanying it. So, and then there's a whole category of other things that are not related to those three diagnoses that we also try to sort through and figure out how best to help patients. A lot of the non-epileptic spells is just meaning that it didn't fit in one of those other categories, and it's probably related to something more complex that we don't understand yet in terms of how stress and how kind of cognition can override sometimes based on the responses to stress and to overwhelming circumstances. So that's a really common presenting complaint. You'll see there in the picture a child with an EEG on their head trying to capture those electrical recordings from the scalp to try to understand if something is a seizure. Oftentimes those spells, we think they might be seizures, or maybe we think they're not quite, but they keep happening. And so the gold standard, the best way to determine if something is a seizure, is actually to record the electrical activity from their scalp while they're having an episode. So sometimes we admit kids to the epilepsy monitoring unit to try to capture that behavior, the little spell, and see if we see an abnormal electrical signal while they're having that spell. And that would be the gold standard to say whether or not that spell is a seizure. That's often hard to do because these spells are unpredictable and can't necessarily be provoked. Sometimes they can, and we use that to our advantage sometimes. But oftentimes they're not able to be provoked, and even sending someone to the hospital and having them sit in a bed with this stuff on their head doesn't get us the spell that we are looking for. And so we have to do other kind of deduction to see if it could be a seizure. And some of that is just understanding what the electrical activity looks like at rest, if there's any signs that a seizure could be possible from a certain area of the brain. So that's a little bit of background about one of the common complaints that would take you to a neurologist's office. Another one is developmental delay. Lots of people see a neurologist for this presenting problem. As a lot of you have already learned, the domains of development include gross motor, walking, your physical function, sitting, fine motor, your ability to manipulate objects with your hands and feed yourself and use utensils and all these sorts of things, language, your ability to have receptive language, understand what's going on, as well as to have productive language. And then social emotional, how do you interpret cues from your environment? Do you make eye contact? Do you understand humor? Things like that. There's a really broad workup often for these concerns. Some people might have delays in just one of those domains. If you have delays in more than two, we classify that as a global developmental delay. And so that all of that impacts the workup that we do. We look for reversible causes of developmental delay with some of our lab tests. And then also look at the genetic underpinnings and try to understand, was this something that the cells were programmed, to have problems with? Imaging factors into that, so we can see if there's a structural abnormality. Was there a clot that happened in utero or in early life that led to those delays? And then we'd look a lot at what the functional and kind of supportive implications are for that. How does someone function in their home environment, and what kind of therapies and supports can we get them on the ground in order to help get them as much opportunity for improving those developmental delays as possible? Some people don't, but when you say developmental delay, it actually implies that it's going to get better just at a slower rate. And that is the case for some kids, but it's not the case for all of them. So we have to be sure to also explain that to our families, that we intend to give the child as much opportunity as we can to make those delays over time, or to make those gains over time to stop having delays. It's really hard for us to predict in the majority of cases where someone might end up over time, and kind of what that timeline might look like. So another opportunity to just talk about what is common in the office. Oftentimes we see complaints about regression syndrome, so times when someone's lost skills within their domain kind of trajectory. Sometimes it's due to stress or, particular situational things that have come up. Someone stops speaking or, regresses with regard to toileting or other things like this. Sometimes a really, really common one is a presentation of autism, and you'll find a lot of variability across neurology practices across the country about who handles autism. Sometimes it is in the neurology office, and sometimes it's through other behavioral specialties like developmental pediatrics or neurodevelopmental specialists, sometimes through the general pediatricians often also take some of that diagnostic work on. We see a lot of regression syndromes or loss of skills in the context of some of our epileptic syndromes, and also the neurodegenerative disorders, which is a huge category there in terms of what falls under that. But it's often some of our genetic therapy or genetic disorders, and we're learning a lot over time about the exact genetic underpinnings of a lot of those things, whereas previously they might have just been classified by the phenotype, what they looked like on the outside. We're getting a lot more genetic information. I wanted to speak pretty explicitly about some of the barriers that people cite to going into neurology. We hear this a lot from our adult neurology colleagues who rotate with us as well, that it's a hard task to be in child neurology for these reasons. Sometimes it's managing parents. People really like working with the kids, but the parents are a whole nother story. And it is true that in child neurology, you have one patient, but you have a whole family that you're often treating. And so you do have to have that mindset to be able to manage the expectations and the anxieties and the hopes and fears of the family alongside the patient themselves, which happens in adult neurology too. You certainly have, the spouse and the adult children and other people who are involved in the patient's life. But that can sometimes be a little bit variable, whereas in childhood, they always have a guardian, they always have someone who needs working alongside to be able to provide the best care for the child. And it's often a burden or an obstacle to overcome when the parents get in the way of providing care to that child. That's a whole nother dynamic and frustration for people sometimes, that you want to help this child as best you can, but that the parents are somehow impairing that or making the situation a little bit harder to navigate. There's a huge amount of uncertainty, both in adult and child neurology, but I think particularly in child neurology, when you're combining the neurophysiology of the brain with development and trying to have time clocks for healing of brain pathways, as well as for kind of plasticity and just how a child might recover. It really depends on what age they were affected, and all of these different variables make for a challenging time knowing exactly what to expect. We do have plenty of literature. There's lots of evidence base for the work that we do, but there are just a lot of factors that go into how a child might recover from something or how their future might look. And so uncertainty comes into play quite frequently in child neurology. And then just the emotional toll, I think, deserves explicit recognition as well, because talking about children who have brain injuries often, or brain diseases, and that is sad for a lot of people. My framing has always been that these children would be affected with it anyway. If I choose not to go into this field, that doesn't do anything for the people who are affected by it. And in fact, if I can help with that difficult circumstance, then that is really meaningful to me, and I'd like to be there to help them with it. So that's how I frame the heavy emotional toll. But it does take acknowledging as someone who's thinking about going into the field, what you're going to do or how you're going to cope or manage all of that emotion and challenge. So I'm going to kind of wrap up the portion of my slides here so that we can open it up for a broader discussion. But I want you to also just encourage you to think about child neurology at your institution. You can ask about specific experiences. There's lots of online resources, and especially over the last few months, there are a growing number of online resources, certainly through the American Academy of Neurology, also through these specific child neurology societies. there are, opportunities to find child neurologists in your local area. Recognizing again that we're in high demand often means that we're not necessarily in all the places where students are. And if there are, a handful of child neurologists, they might have a harder time accommodating multiple requests. And so just trying to get you in touch with the people who might be able to help is really important, and I'm happy to help with that. And then just wanted to give a few parting thoughts as far as my reflections on my medical school journey into residency and beyond. Again, I think you've probably heard this from other people as you look for the type of specialty that you might go into, but you're looking for your people. You're looking for the people who like to work like you do, who maybe cope with stress similarly, and who kind of accommodate different quirks or different interests that you might have. Again, we don't want a whole group of people who are all the same, but it does help to kind of feel like you have a common theme with the people that you're going to be spending a lot of time with. So keeping an eye out for the people that seem like they would fit with you or work with you. Recognizing the bread and butter, that's what I tried to give a little bit of an overview of in this slide deck, but there's plenty more to be said about child neurology and the common things that show up in the office and in the hospital. But just making sure that whatever specialty you're looking at, that you're finding out what is that bread and butter. Is that something that can pique your interest through a long work week, and is it something that you can, even when you feel like your bandwidth is limited, be drawn back to? I want to kind of put a plug in for people to always remember to invest in yourself anywhere you are on your medical school journey. I think one of the ways that I found really helpful in medical school and residency and beyond is to always be celebrating your own achievements. I think we don't do enough recognizing of each other, but we also don't do enough recognizing of ourselves about the things that took a lot of time or bandwidth or energy, even if it's just, celebrating the end of a clerkship or something that you worked really hard on. I think it's really important to celebrate yourself and to make sure that the people who are in your village and your community know that you've just done something really hard, that you've put a lot of energy into. There's no shame in trying to congratulate yourself on a job well done. I think that's really important, and I think medicine won't do that for you, so you have to remember to do it for yourself. Again, a thought about building and maintaining your community. Medicine picks people up and puts them down in a lot of different places, whether it's rotation to rotation or physical locations, doing medical school in one place that might be at home, or it might be far away from home, and then thinking about going to a residency that might be in a whole nother place. And I think in our current environment, people pick up and move fairly frequently, but I think medicine does that to people to an even greater extent, making them move around for this job or this training or this opportunity. And so just making sure that you take time to invest in your community and yourself as well in that process. And then something that I think has been kind of coming into vogue again a little bit more is the aspect of kind of managing your mind while you're in medicine. I think medicine, medical training, medical school, and residencies and all sorts of things can give you the mindset that you are at the mercy of a lot of different circumstances, whether it's the pager or the number of patients that walk into the emergency room or other things like this. And so it's really important to consciously be taking back some of those narratives about how you have control over your situation, and a lot of it is based in kind of the cognitive behavioral therapy work, but I think it's particularly relevant in our era of burnout, and trying to keep resiliency by not just doing more deep breathing or yoga or other things like that, not to add more to your plate, but to actually manage how you think about your circumstances and to keep your mind strong through all of it. It's a really important part of it too, and I can speak more about that, but these are all just some of my pearls of wisdom for you all as you continue your medical training. So this is actually the end of my presentation, so I'm going to stop screen sharing and get to the chat box over here. And we can go from there. Let's see. All right. So I'm going to scroll up. Thank you all for putting all of your welcome messages in there. It's great to see you all represented from so many different parts of the country, different parts of medical school training. This is great. Good. All right. So there's a question here about a community for general child neurologists versus subspecializing further into adult neurology. I think that you'll see both. I think that for child neurologists, there will always be a need for general child neurology. It is such a broad field, and again, with the limited supply of child neurologists, unless you're at a big center, like a tertiary children's hospital, there will always be a need for you to be somewhat of a generalist. Lots of times, being on the inpatient service, many child neurologists have to do some amount of inpatient child neurology in addition to their clinics. And so you will see everything that comes in the door there. And so I think there's a big push for people to stay very comfortable with their child neurology skills in a general sense. But then there are all of these opportunities to subspecialize. Oftentimes that subspecialty will mean that you'll end up at a bigger center, but they're always in demand. People always want a headache child neurologists. Epilepsy doctors are really in demand, reading those EEGs. And right now through technology, you can do that remotely. There's a lot of opportunity there to be in different parts of the country and still have a great job and to be kind of, in a sense, writing your own ticket to be able to do what you want to do, where you want to do it. But yeah, so there's I think a lot of desire and demand for both, for specialists and for generalists. Let's see. Neurorehabilitation. Oh yeah, that's a great question. So we do have a lot of overlap with PM&R, and I would say I haven't seen specifically within child neurology subspecialty fellowship for neurorehabilitation, but I think that it certainly could be something that someone delves into in partnership with their PM&R colleagues. Certainly when there's rehab jobs, I've seen it more on the adult side, probably, that neurologists can take some of those rehab jobs. I think a lot of the rehab work in neurology came kind of under the neuromuscular section for a while. But I think certainly in the era of, all of the focus on brain injury and rehab there would be certainly opportunity for it. I'm just not aware. I don't know, Dr. Saeed, if you know of other opportunities for neurorehabilitation within the field.
Yes. First of all, such a great overview, Dr. Treat. We do actually, I have colleagues who do neuro rehab. It looks a little different. So when you say neuro rehab, it's so broad. So what do you mean? Do you mean like you're running a rehab center, or are you maybe managing a large population of children with cerebral palsy, doing Botox injections, working in multidisciplinary clinics with physical therapy, occupational therapy, even with physical medicine and rehab doctors? So there are ways that you can do that. I actually have one of my own trainees this year where we've kind of customized her educational curriculum so she has longitudinal exposure with PM&R so that we can kind of give her that neuro rehab training during her general child neurology training. So I think the bottom line is that probably exactly what Dr. Treat said is that we're flexible. Our programs want you to be who you want to be. You have a bunch of elective time. And so that's maybe something as you're looking at programs and when you're on the interview trail to kind of ask them, how would you manage this interest that I may have? And so I think you could definitely make that happen if that was your passion.
I think that's great. Thank you for filling that in. I think one of the other things to point out about child neurology as a subspecialty in comparison to other pediatric subspecialties is that combined approach where you get to do the 5-year program is a little bit different from all the other pediatric subspecialties. So pediatric GI or pediatric cardiology or all of those other things, they would do a 3-year pediatric residency, and then they would match into their 3 years of subspecialty training. So we take our 3 years of subspecialty training and shave off one of those years of pediatrics and do that 5-year combined program. Now, in all the other pediatric subspecialties, they generally, this isn't always the case, but they generally do an intense clinical year in their first year of subspecialty and then have 2 years of research time where they do still some clinic stuff, but they often have major research focus during that time. And that's usually not the case in child neurology. Some institutions do have infrastructure for you to do more of that research during years 4 and 5, or maybe interspersed throughout that whole 3-year period. But it's not set up in the same way that other pediatric subspecialties are set up. in that you do that first clinical year and then 2 years of kind of research and electives. So just to give you guys some of that background information too about how that's set up within child neurology. All right, I'm gonna look back at the chat box. What kinds of child neurology diseases or pathologies do I see in my practice? Outside of palliative care, do I take care of regular pediatric patients? So if I understand the question right, they're asking kind of what I see in the office outside of my palliative practice. It's very interesting, actually. In my palliative practice, I actually end up seeing the textbook of child neurology because I see patients who have all sorts of oftentimes terrible neurologic diseases, but the ones that you read about in the textbook, whether it's leukodystrophies or Batten's disease or you know, other neurodegenerative conditions, metabolic conditions, all of these things that have a shortened life expectancy. In my general neurology practice, I also see some of those things as well. Often it's for diagnosis. And at my center, where there are a lot of child neurologists who have all those different subspecialty trainings, oftentimes I'm involved in the diagnosis, and then they might go to a movement disorder specialist or, you know, an epileptologist or something like that in addition. And sometimes that is variable too. Sometimes the primary neurologist would hang on to those patients and get consultation from those subspecialists versus handing over the care to those subspecialists, depending on what the disease is. I'm also really involved in our neuromuscular group through my palliative care work because they see a lot of the spinal muscular atrophy and Duchenne's and a lot of the other, again, genetic conditions that they're working on therapies for, but have, you know, just a lot more decision making potentially to do in those diseases. So there's again a huge breadth. I hope that answers some of the question about some of the diseases and pathologies in my practice. The next question is about boarding in peds as well as neurology at the end of residency, asking whether it's a common practice to do both. So I think that also has a lot of variability across the field. At my institution, I would say it's the minority of people who do their general pediatrics boards in addition to their neurology boards. You certainly are eligible for both at the end of your 5-year training, but you're actually not eligible for your Gen Peds boards until the end of that residency training, till year 5. And so because of that, some people feel like they're already 3 years out from being a general pediatrician, and it's harder to come back around to that test at that point. I don't know, Dr. Said, if you have other insight about that from your trainees.
Yeah, I think the people, just so I can give you context, I've been a program director at UT Southwestern in Dallas now for, this is my 16th year, so we've been doing this for a while. So what I find is the people who did 3 years of pediatrics, they are, and then come into neurology, they almost always, I can't really think of a single exception, they always sit for their pediatrics boards because they've done 3 years. Maybe they realized they were interested in neurology as a field during their peds residency. They didn't know quite when they were a student. So that's why they finish maybe 3 years of pediatrics, and then they take their exam in their first year, usually that October of their first year of child neurology training. For those who are doing sort of our categorical track, which is 2 years of pediatrics and then 3 years of neurology, it really is almost rare is even, it's less common than rare that they would go on to do pediatrics boards at that point. So, but I think that, you know, you kind of self-select and you realize that this is what you want to do. And we work in close partnership with, let's say, our complex care pediatricians or our general pediatricians in the community. And then it is funny, they still often come to us because they know that we're their home. They often see us a little bit more even sometimes than their pediatrician. And so we are happy to sort of deal with sort of straightforward things, but I don't really ever prescribe a medicine for their otitis or their UTI because there's so much neurology that we are only the ones who can do. So we work in close partnership with our pediatrics colleagues.
Yeah, thank you. And I think that piece, that meaningfulness behind it, the person who had asked this question was asking about if you could take over certain primary care duties for your patients. Certainly, you know, like Dr. Said was saying, you can for some of the basic things, but there's really so much to work through just from the neurology side. Some of my other colleagues that have done it, one was a headache doctor and wanted to be able to do headache medicine kind of in the setting of a primary care practice, so wanted to keep that general pediatric set. So you end up sometimes taking a pay cut a little bit to do that too, because of the general pediatric salaries compared to the subspecialty salaries. So I would encourage you, if you're thinking about it, to kind of understand your motivation behind it, because it does require a lot more, studying and money and keeping up with another board certification and other things like that too. So just some things to think about. Let's see. Would a child neurologist follow pediatric patients they see into adulthood? Yes. So we at our institution follow a lot of people into young adulthood. A lot of it depends on what your adult neurology counterparts look like. So if you have if you have a movement disorder patient, this dystonia patient, is that dystonia patient someone who has a shortened life expectancy, like for Huntington's, juvenile Huntington's or something like that? Or would it be someone who is expected to live into a normal adult range, and so maybe they would transfer over to their adult colleagues, adult counterparts, if they were available. If there is that shortened life expectancy, oftentimes we'll try to work with them to be able to not have to manage a transition in their team, depending on what that looks like. And I think at big pediatric centers that's a common situation where young adults, even into their 20s and maybe early 30s, depending on what the conditions are continued to be followed by their pediatric doctors. A lot of those conditions, a lot of the things that have gene therapies now, people are living longer with them. And so we're starting to see more of that impulse to do transitions. Transitions is actually a huge focus within both the Child Neurology Society and the American Academy of Neurology about how to navigate that thoughtfully, and who should be transitioning, and what is kind of that break point of when should be your standard practice, and what are some of the factors that you might use to fudge that a little bit. So it's very common, and I think it's being navigated thoughtfully on both sides, from the adult side as well as on the child side. And there's a lot of room for the pediatric neurologists to help educate the adult neurologists too about what some of our pediatric diseases look like as they grow up. So great questions. All of these are great questions. Another question about transition. Good, this is on the same topic. Do we find it difficult to transition patients that you've been following for many years? Yes, the families find it difficult, the neurologists find it difficult, everyone finds it difficult. We know we should do it for their best interest, and a lot of times it does have to do with that psychological piece about if the person has a cognitive ability that allows them to engage in those types of decisions, if they're going to move out of their house, if they're going to be more responsible for their own care. That's often a really important part of it, is to get you plugged in with an adult neurology doctor who's going to treat you like an adult, who's going to tell you that you need to be responsible for refilling your medicines and all these other things. And some of that is kind of a natural point as you break away from your pediatric office, where you've previously been kind of facilitated to a greater degree about just maintaining your health through other people's prompting. Let's see. Speak more about my experiences with work-life balance in child neurology and palliative care. Sure, yes, happy to. I think we don't do enough talking to medical students sometimes about what real life, the work-life balance. I think people often gets a bad rap because it's not this seesaw that balances perfectly like this. It's a balance because sometimes you're up and sometimes you're down, and you have to use your own internal barometer about how much recently you've been up and how much recently you've been down, and how you need to adjust for the next weeks and months to get that maybe seesaw to go back the other direction. Maybe it's going to come more towards the center, and maybe it's going to swing the other way for a little while. And overall, you have a sense that everyone's getting what they need, including yourself. There's I think in medicine, a big self-sacrifice culture about putting patients' needs, colleagues' needs before your own, and kind of remembering that you also get a piece of that pie to carve out for yourself is really important. For me, a lot of it was finding those people who could remind me about myself throughout medical training, whether it was in medical school or in residency or even now, as I got buried underneath whatever the current focus was, people who would be able to say, like, that sounds exciting and you're doing great work and all these things, but it sounds like something's missing, or it sounds like, you've been talking about this and sacrificing your sleep and your well-being and other things for this important thing, but kind of for a long time. Did you realize that it was as long as it was that you've been doing that? You know, like, what's your plan here? What are you going to do to help correct this into the future? And so that's been a lot of my workaround, is to try to build that into that kind of accountability a little bit. It feels bad sometimes. It feels good sometimes to have people that know you, but it also can feel like, hey, I'm trying to do a good thing here. You know, what do you mean? Like, you're not just going to be supportive, but that's actually the best kind of support, is people who are going to say, you know, I'm really proud of you. I think you're doing great things, but you also need to take a good hard look at how much you're sacrificing for this very important goal over time. So keeping those people close, even when you don't necessarily want to hear what they have to say, is an important thing. Dr. Saeed, do you want to chime in on that too?
So so I had kids in training also. So, you know, although I'm at sort of the other end now, they're 21 and 18. So yay, you will get there. The biggest thing that I found is that work-life balance doesn't look like a balance that you have every single day. I thought it was. I thought it meant that today I was going to be an outstanding mother and physician and wife and daughter and friend. And I realized that it kind of changes. So maybe this block, when I'm doing more in hospital service, that my patients take more of my time and my teaching takes more of my time, and that maybe this is where I have a wonderful life partner and we can balance those things, but it doesn't look the same every day and every week. And so if you know that, you kind of look at the long view, it really does help. The other thing that helps is understanding that residency is a very transient part of your existence. You know, you can't look at residency as your forever. And if you see that, you realize that as an attending, you really have a lot of ability to live the life you want, to pick the job you want, to tailor your career the way you want. And it doesn't mean that you may not be making sacrifices, but you can do that. And it took me a while to have that realization. So that's kind of the empowering thing, is, you know, get through that initial phase, and then you can decide. Every year I run a camp. I'm the medical director for a camp for children who are living with epilepsy. They're teenagers. We have 120 kids in July in Texas. That is a rejuvenating part. You know, that feels a very important part of my needs. And you can figure it out. Find good people that you think are doing great things. Help, you know, find them as your mentors, and they will help guide you through some of those things. That's my work-life balance little spiel.
That's great. Thank you for adding that. I'm going to go back to the chat box here. Specializing in palliative care, changing what kind of patients I see. Yes. So like I mentioned, the palliative care work that I do is actually general pediatric palliative care, so all children with serious or life-altering illness. But my dream, or my vision, is to actually do specifically pediatric neuropalliative care. So trying to, it's really a huge overlap, the population of children with neurologic impairment. You can imagine all the cerebral palsy, all the hypoxic ischemic babies that have issues growing up, as well as all of the other regression syndromes and other things that we see in the normal child neurology practice. There's a big overlap with all of those families having just a lot of, like I said, decision making to do. I think also, from going back to that sense of being profound, working with the nervous system and that being profound, it really changes the way that parents relate to their kids when they can't walk or talk or speak with them, or sometimes even smile. And so that was how I was actually drawn to palliative care, was in my general pediatrics years, seeing families care for their children with serious neurologic disease, and kind of looking for those opportunities to have discussions with providers in the medical context to say, I don't know how to relate to this child, or I don't know how to make decisions on behalf of a kiddo who's not going to go to school like a normal child, or feed, or, you know, have these other things that we dreamed about when we thought about having kids, and how do I reconcile that? So that's kind of, in a nutshell, where I got that interest. There's lots of other medical specialties who can come into palliative care. It can most people are probably general pediatricians or family medicine doctors or other things like that. There's actually only, I think, 3 or 4 of us that are child neurologists who do pediatric palliative care. I think it's coming. I think everyone recognizes that primary palliative care, or like frontline general palliative care, is involved in the care of a person who has a neurologic disease. And so all neurologists to some degree do primary palliative care. But to kind of have that more explicit carve out is something that's just been recent, and I think it will continue to evolve. So let's see. Speaking a little to the application cycle for child neurology. Great, and I actually might throw this question over to Dr. Saeed as well, but thinking about some expectations for changes in the application cycle. I think that there's a lot of prep work being done through the Academy and through institutions all across the country about what it will look like for this year's recruitment season to go virtual. And so there's resources that are coming out through the Academy about some tips, and maybe some of you took part in the questionnaire that was sent out earlier a few months ago about things that you'd like to see as resources being built for the virtual application season. Know that we heard all of those responses, and you guys had great suggestions, and we're all validating what a chaotic time it is. I personally haven't heard anything about changes to the timing of the cycle. Dr. Saeed, do you know anything about different?
Yeah, I think that really the biggest change is going to be that it's all virtual, that listen to the tips. Your universities are coming up with them. The American Academy of Neurology, there's great committees. Dr. Treat's on one of them that's coming out with putting some information for you. I think ERAS, the submission has been delayed a little bit, but actual match day is still the same. And then I think you want to understand that as program directors, we know that you didn't get to every single sub-I you wished you had done. We understand that you may not have sat for your STEPS exams necessarily. We understand that you don't have a letter from a neurologist perhaps yet. That's okay. We are going to look at you holistically. And so just know that to help minimize some of the anxiety. We get where you are. We're here to support you through that.
And just letting you know, we have about enough time for about one more question for now.
Great. I'm going to answer one really quickly, and maybe we can even squeeze another one in. Someone asked if there is opportunity to travel for different needs to provide care across the country. There is always opportunity for what they call locum tenens for child neurologists, which means you do temporary jobs at different institutions. Sometimes there's outreach possibilities. So for example, my hospital here in Colorado, we do outreach to the different, basically the 9-state region around us. So people travel to Wyoming, they travel down to the southern border to provide care for people in New Mexico, and kind of try to intersperse all around that, even over to the western slope towards Utah. And then there are also opportunities if you don't have one single home base to again do that locum tenens work, which is a little bit more piecemeal, but sometimes people find that really appealing. There's been this kind of constant ask for a child neurologist up in Alaska. I think I mentioned that too. And so I've had a colleague and we've tried to brainstorm about how we could trade off houses or something like that, because he has a few kids and I have a few kids. And anyway, it's a bit of a pipe dream, but there's really a lot of opportunities for different parts of the country. And then the other question I was just going to give a little brief note to is someone was asking about the psychological piece or the behavioral aspect of child health with pediatric neurology, and whether I dedicate a certain portion of time to promote their development or feeling resilient or confident. For me, a lot of times it's a quick assessment that I do in the visit in terms of how do they feel like they're integrating with their peers at school, how do they feel like their disease is somehow impacting their self-concept in a negative light. And then we really underestimate the amount of power that we have as their physicians to affirm them, to say, gosh, you're doing so well in this aspect, or, you are a strong kid who is managing your disease, with great, grace or whatever it is, and then refer them, get them plugged in to some appropriate behavioral health services in those cases where they need it. So it's not always coming from me, but it is that recognition that I have a really important part to play in it, and can be that conduit to getting them into some of the other services, whether it's with a school psychologist or a third-party community agency or other things like that. So anyway, brief overview. Thank you all for your participation. Really, really excited to have you on the call with us and to hear of your interest in child neurology. Hope it was helpful.
Awesome. Thank you so much for all of your time and answering all your questions and giving your knowledge to us. I linked in the chat a quick survey that's just giving some feedback on the talk today. We will be hosting more of these throughout the rest of the year, as well as some case studies, and feel free to look at the medical student synapse for that as well. If you have any questions, feel free to email me, ggates@aan.com. Thank you again to Dr. Treat and also for Dr. Saeed, who got to join us today. I'll be around and holding this open for a little bit so people have time to get that survey done. But thank you again so much for coming.